Now we are live on YouTube. So we'll start in another 30 seconds. Shall we start now, sir?
Yes, please go on.
Good afternoon, everyone, and good morning to some of our friends who are joining from this part of the world. We are very happy to have you all here for the collaborative webinar series as a collaboration between the Indian and Malaysian Associations of Sports Medicine under the aegis of the Asian Federation for Sports Medicine. And to tell you more about it, I would request the President of Indian Association of Sports Medicine, Professor Arumugam S, to give his introduction and followed by an overview of sports medicine in India. Professor Arumugam, sir.
Hello, again, good afternoon and rather good morning to some of you. It gives me a great pleasure in inviting you all to this webinar. I would rather say it's a global webinar. As my colleague Dr. Tyagarajan mentioned, it is the initiation of Indian Association of Sports Medicine along with Malaysian Association of Sports Medicine, which is accredited by Asian Federation of Sports Medicine. And I would like to thank Dr. Tyagarajan at this point for his untiring effort and really put up an excellent program. And it's going to last over a month, 8 days, more than 30 lectures covering various aspects of sports sciences and involving more than 30 international faculties from over 12 countries. So it's really a global in the sense. And the way we structure is also interactive. So the audience can give the questions in the chat box. And the moderator will kind of put that onto the speaker so that it becomes really didactic lectures. So without taking much of the time, I'll go to the first lecture of this session. Unfortunately, the patron of Indian Association of Sports Medicine, Professor Jaspal Sandhu, not able to come due to unavoidable circumstances. So I'm going to give a lecture on, let me see, I have to share. I've opened my screen, but it's not sharing the.
Yes, sir. It should come, sir.
It is not showing the my lecture on the screen. Should I open my Keynote?
Yes, sir. You can do that, sir.
Usually comes very. It doesn't show that.
Yes, sir. Can try again, sir, please, sir.
Do share again?
Yes, sir.
My screen is not showing. My desktop is not there. Something is. Let me see.
I'm able to share the screen, sir. So maybe one more trial.
Okay, so see when I say share, okay, they're asking security. Can you see the screen now?
Not yet, sir.
Maybe I'll ask John to give his lecture, then I'll come. It's never happened to me with the Zoom. Usually it's very simple. It all says keynote, but it says unknown. I think I need to authenticate or something.
Yes, sir. Maybe, sir. Maybe we'll ask John to present his talk, sir.
Yeah.
I can do that.
Yes, John. May I request you to give a talk? And as an introduction, probably Dr. John Patricios needs no introduction to all of us in sports medicine. Reputed sports medicine doc in South Africa, and worked with a couple of universities, and he has got some special interest in the areas of concussion. And today he probably could base upon COVID-19 and its implications on sports. Dr. John, stage is yours.
Thank you very much. First of all, thank you very much for the invitation. It's always a great pleasure and an honor to present on this forum. And also congratulations on your continuing education program, which is really contributing a lot worldwide to sports medicine. So thank you for all that you do. So my brief today is really to discuss some issues around the current situation we find ourselves in regarding COVID-19 and its implications for sport and exercise. So in 20 or 25 minutes, it's difficult to cover everything, but we'll try our best to cover some of the key aspects and challenges that are facing us in this environment. So I think sometimes if we look at where we are, we feel a bit like this, that everywhere you look, there's an issue related to COVID-19 and coronaviruses, etc. And your head gets a little bit cluttered. And as a clinician, sometimes it becomes difficult to make clear decisions. But that's what we're being asked to do, is to make clear decisions in the interests of those who want to exercise, and in particular for professional sports persons who earn their living that way. So we're going to look at a couple of ways of maybe working our way through that clutter. And I'm going to cover mainly these 5 issues here. I'm going to look at the context of coronavirus and some of the key issues related to it. We're going to focus a little bit on the immune system, the virus itself, and exercise and its role in the immune system. Look at how we can facilitate exercise for all, because 90% of the people that want to exercise are not professional sports persons, and we need to look at facilitating exercise for them. Discuss a little bit about the financial pressures which are a reality at the moment in sport, and then as a medical fraternity, look at how we are going to respond to that. So I thought I'd start with a little bit of context, and it's a very interesting time for us in the world, but particularly for us in South Africa, where we are on an increased trajectory, and my colleagues in India will be very aware of their current situation as well in terms of the number of new cases. So there are areas of the world, and these are just 2 of them, where the trajectory is on a steep incline, and in the face of that, we're being asked to reintroduce sport, which is very challenging. Some other interesting statistics. I've given similar talks over the last few months. And when we gave our first talk at the beginning of a lockdown period in early March, the COVID-19 contribution to daily deaths was some way down the ladder. We spoke a few weeks later, towards the end of April again, and when I presented a similar slide, it had moved up to that sort of level into position number 6, and that's where we are today in terms of the average deaths caused by COVID-19 worldwide, and I'm sure it will be at the top of the list very shortly. So it has become a very, very significant pathogen and disease entity that we have had to learn to deal with. And as I said, in certain areas of the world, and in my area in particular, it is escalating to a degree where we are reaching the peak and high numbers of new cases every day. A little bit about the virus, and I'm not going to turn us all into virologists, but we're all aware that there are various types of viruses around, and they cause viral infections. Just in terms of the terminology we use, the coronavirus, so-called because it looks like a crown, and it's one of a group of viruses that look like that. This particular virus is called the SARS-CoV-2 virus, and the disease that it causes is called COVID-19. And two of the important factors that we need to consider are its infectivity, how infectious it is, and its severity in terms of how serious the disease is. And we're going to discuss a little bit more about those issues as we go on. In terms of some of the key structural aspects of this virus, there are three that I want to point out. One is the actual RNA genome. And this is really the genetic material that allows the virus and its message to multiply. But it can only do that in a living being. So it needs to be inside a human being to do the damage. When it lies on a surface, it's of no good. It's just really an entity. But it becomes let's call it a living entity once it enters the living system. And that's why it relies on us as humans to make it a viable and transmittable disease. The second important thing is this spike glycoprotein, which attaches to the ACE2 receptor. And it is a spike, so it sort of adheres to it. It's got glycoprotein, which is sort of a sticky substance. So it's a very sticky sort of virus that actually adheres very effectively to those receptors. And that's also one of its predominant features that creates trouble for its host. And then the final factor I want to talk about is this envelope. And in the coronavirus, this envelope happens to be made of lipid or fat, which protects it, but also makes it vulnerable. And it makes it vulnerable to two things. One is soap. So just like when you're cleaning some oil out of a pan and you put soap on it and it allows you to get rid of that oil, so soap and water allows us to break through the lipid envelope and destroy the genetic material in that virus. And so it makes it very, very powerful. And alcohol sanitizer does a similar thing. So I point those out because those are key aspects of the virus which we as clinicians need to take into consideration and strategize to counter the virus by understanding why it and how it transmits its infective disease. In terms of infectivity, it's a very interesting scenario. So if we look on the x-axis here and you look at how infective a condition is, you'll see something like chickenpox is very infective. So if you get exposed to chickenpox, you will almost certainly contract it. Whereas on the y-axis here, we can see the percentage who die. Nobody really dies of chickenpox. You will almost certainly get it. Similar to the common cold, you won't really have a serious illness. Something like Ebola is less contagious, but it kills 1 out of every 2 people who contract the virus. So COVID-19 is very interesting because it's somewhere in the middle. It's infectious, but not that infectious, and it's actually not very deadly. It doesn't kill that many people. But because it doesn't kill that many people, it gets transmitted very easily, and then so it becomes a very dangerous virus because of its infectivity and the fact that it spreads from one person to another quite quickly without doing damage unless you're one of those vulnerable people who we know about and who we'll discuss. So it's infectious, but not too deadly. It affects a vulnerable population far more than it affects others. And it has a number of other aspects around it which create problems for us. One is that we don't have an innate human immunity against it. The next is that it attacks the respiratory system. So when it affects your breathing, that makes you very vulnerable. There's this concept of the cytokine storm, or the inflammatory response of the body's innate immune system, which in itself can create some degree of toxicity or toxic response in the body. It's come at a time in our 21st century lifestyle where there's been incredible amount of travel, people interacting closely, as we know, in its origins in China from the markets in a very populous country. And so its ability to spread was really facilitated by that lifestyle. And it's coming to an environment where we have no treatment for it and no vaccine. So the combination of all those factors has made us very vulnerable to the spread of this condition. In terms of morbidity, we know that most people will have no symptoms or very mild symptoms from it. And they will, however, be able to transmit that to the smaller numbers who may require hospitalization, and the smaller percentage, even under 5%, who may become critically ill and require intensive supportive care. And so it's not a very severe virus for most people, but in those who are vulnerable, let me go back to that, and we know who those are, and worldwide, although these data come from Italy and the UK, worldwide the statistics have been very similar, over 60 and with a number of comorbidities. And the greater the number of comorbidities, the greater your risk of dying from the condition. And so we've got this cohort of older people with comorbidities who are at greater risk. So interestingly enough, if we look at those comorbidities, and we're coming on to the exercise theme now, and we look at what makes you vulnerable to COVID-19, it really correlates very well with a similar list of conditions which exercising individuals are protected from. And we know that if you exercise, you have far lower incidences of what we call non-communicable diseases, such as heart disease, hypertension, diabetes, stroke, cancer, and dementia. And that's the very group that is vulnerable for COVID-19 severe infection. So one of the take-home messages from this pandemic must be that people who exercise regularly will be at lower risk for this sort of condition. So exercise should really be an inherent part of our prescription on an ongoing basis, and that's a very important take-home message. When we look at the body's immune response, it's very important to understand this, because this, in effect, together with hygiene practices, is all we have as a defense against this virus. And we have two aspects to the immune system. One is called the innate immune system. So the innate immune system really refers to a group of cells that lie in waiting for pathogens. So they make contact with the pathogens, and they essentially phagocytose or ingest, kill those pathogens as they come into contact with them. And there are various cells which we're familiar with: the neutrophils, the macrophages, the mast cells, and the dendritic cells. And most of these cells also secrete molecules that act on blood vessels to enhance recruitment of more inflammatory cells. And that's very, very important, because once you get exposed to a virus like the SARS-CoV-2 virus that replicates so efficiently in the living being, you need help. Your innate system becomes overwhelmed, and as a result, it releases all these chemicals, which are really signals to bring more cells into the system to try and help fight the condition. So those are cytokines, chemokines, histamine, and other pro-inflammatory mediators that are sending signals to other innate immune cells and cells of the surrounding tissue to really try and assist in this innate immune response. And that allows proteins from the blood to enter the tissue and interact directly with those pathogens. Complement proteins become activated, and that enhances the ability to phagocytose or destroy these pathogens. Over time, that's a period of days really, after a few days, your body starts to adapt an immune response to these particular pathogens. So the response moves from just a generalized response to a very more specific response. And that is the responsibility of the lymphocytes. And there are really two types of lymphocytes, the T cells and the B cells, and their various roles are described there. but that results in
That's
a response which is specific to that particular pathogen. And as a result of that, you're left with some degree of protection as a result of having antibodies, which next time they're exposed to that pathogen can directly counteract them and neutralize that virus before it does any harm. And so it's a much more specific system to that particular virus. It's also able to distinguish between the pathogen and self, and it has a memory which may last several months, it may last years, it may last forever. And obviously you'll be aware in the literature that there's some discussion at the moment as to how long your protection against SARS-CoV-2 will last. So let's get on to the role of exercise, because we've highlighted that exercise has significant effects on on the ability of the body to fight the virus. And I've pointed out that it does an incredible job of promoting the innate immune system. But what about our more elite athletes who train at a very high level? And there is some evidence and several studies which are quoted here that high intensity or prolonged strenuous exercise may actually have a transient decrease effect on the immune system. And what's very important to understand about this is that this is certainly going to be exaggerated in those people that aren't used to this exposure, but those that have had a period of adaptation and a build-up will certainly be able to adapt to it without it compromising the immune system. And if you think of, for instance, our Olympic athletes, our rowers who might be training 2 high-intensity sessions a day for many days of the week, they certainly have adapted to that. You also need to be able to periodize your training to allow for high intensity, lower intensity sessions, and obviously building recovery, both physical and nutritional and mental recovery into that. So although high intensity, prolonged strenuous exercise has been shown in some studies to cause a possible transient decrease in the immune response, it can be managed effectively. And overwhelmingly, the role of exercise as an immune booster has been validated. We know that regular exercise has huge benefits in terms of its cognitive, social, emotional, and physical effects, but it has direct effects on the immune system, which are illustrated here. And as a result, we now recognize in a pandemic such as this, the benefits of regular exercise on the immune system, that it increases the exchange of innate immune cells, that it has a cumulative effect. The longer, the more often you exercise, the greater the benefit, that there is a 40 to 50% decrease in upper respiratory tract infections in people who exercise regularly, that there's a lower death rate from flu and pneumonia, enhanced response to vaccinations, and we look at immunosenescence, which is the aging effect on the immune system that is delayed and decreased in people who exercise regularly. And then finally, the best response to exercise is in obese, hypertensive, diabetic, and cardiac populations. So if we look at that, those criteria are hugely significant because we're dealing with a virus that causes flu-like symptoms, causes people to die from pneumonia. It causes an increased effect in the aged, and it has a vulnerable population, which includes obese, hypertensive, diabetic, and cardiac populations. So those are the very people who are going to benefit most from exercise on a regular basis. And there's an excellent review article that summarizes all of these, which I've quoted there. So one of the take-home messages from COVID-19, we've always known that exercise protects against non-communicable diseases. We now know that it protects against communicable diseases as well. And that's very, very important, I think, to convey to our colleagues and to the public. So when we came to a lockdown situation, certainly in South Africa, the government prevented people from exercising. And appreciating the effects of exercise on the immune system, a group of us wrote this paper, trying to convince the government that there were some aspects which we shouldn't be locking down on. One of them was exercise, and we should be in a safe environment facilitating exercise in public spaces. in a controlled way together with good hygiene practices, but we needed to try and promote physically distant sports. We need to find a way of allowing school children to exercise and of facilitating team sport activities where it was safe to do so. In other words, we need to prioritize exercise and try and allow people to exercise as much as possible to gain the immune system benefits. And that can be done for everything from exercising at home, and we all know what's become available to us over the past while in terms of technology in particular, the types of Zoom workouts that are available, the trainers who can train you online, etc. But rather than look at the sort of traditional 3 to 5 day a week, most days of the week, 30 minutes at a time, we would implore people to exercise every day, often more than once a day if you can, with different types of exercise, and to bring in a variety of exercises. So you may have a cardiac or cardiovascular type of exercise, and you may also have strength type training, which will add benefit to your conditioning. So exercise at home and in a lockdown environment is very important. Equally important is to exercise safely. So exercise by yourself, not in groups. Exercising outside is lower risk. When exercising, keeping an increased physical distance, making sure that the hygiene aspects are scrupulously adhered to, self and equipment, utilizing a mask as much as is conveniently possible, and then making sure if one does contract the infection that you receive the right sort of medical advice in terms of going back, which for the general population would really be usually about 10 days after becoming asymptomatic, and certainly in people who had moderate to severe illness and those in the vulnerable population groups being cleared by a doctor, particularly from a cardiac and a respiratory point of view. I thought this was quite disappointing advice from the World Health Organization, who suggested we shouldn't wear masks when exercising because it makes breathing uncomfortable. I would really advocate that you wear a mask whenever possible, that you clean that mask after use, and that you try and use a much bigger physical distance than the 1 meter advocated here during exercise. So I think this is a much better infogram here, which is showing us that you really should use a mask whenever possible. You can sanitize regularly, you can clean the mask, and you should really think about every aspect of preventing this virus while you're exercising. And I think that's a very important message again. Exercise, but do it as safely as possible for you and for those around you. I think although it's a medical discussion, it's very important to understand the financial implications of COVID-19 to sport, and in lockdown in particular. And I'm not going to go through this in detail, but just here are some of the major events worldwide which have been impacted. And we know the postponement of the Summer Olympics, which should have been taking place now. We know what's happened to football around the world, major income generators in countries such as America with basketball, etc. So with those financial pressures and the loss of income for players and management, etc., it's become very important to try and facilitate sport because it's under pressure. So in facilitating a return to sport in this environment, we have to take a number of factors into consideration if we want to get back. One is exposure to the virus, which, as we saw in those slides around at the beginning, is all around us, particularly in certain countries. And there's exposure for athletes, their support staff, and obviously their families as well. Crowds become an issue, but obviously getting rid of crowds will take that risk away. We need to obviously look at the environment in which these players are participating, some of which are very high risk at the moment. We need a strategy to deal with infected athletes, and we need a strategy to deal with potential injuries as a result of a long layoff and the athletes being suboptimally conditioned. So those are some of the issues that we might need to deal with. So one of the positive effects of this pandemic has been the amount of research that's been generated. So a lot of guidelines have come about in terms of what we should be doing, and you will have read, I'm sure, many of those. But a lot of it is really expert opinion, and some of it, most of it is not evidence-based, and certainly not evidence-based on SARS-CoV-2 research yet. That is probably going to come soon. And we need to really use the best empirical evidence that we have, and that's what a lot of these papers and guidelines have done. And so the general advocation is that we should be protecting our sports people, and most of the models work around a bio bubble or biologically safe environment, regular screening, and regular monitoring. And those are really the principles in terms of returning our athletes to sport. So as clinicians, what is our response going to be? And it's quite difficult to give a definitive answer. We can certainly say this is where we are now and these are where our guidelines are. But I think if we think back 3 or 4 months at the start of our exposure to this pandemic, what our thoughts were on many aspects of it, they've certainly changed over that period. And as we learn more about how our sports people react to this, our approach to the clinical aspects will change as well. Nevertheless, I think what we do need in dealing with this moving target is a structured, stepwise approach to return to sport while acknowledging that this may change as we learn more. We need to accommodate a spectrum of disease. We need to be increasingly aware of multiple organ involvement. It's not just a respiratory disease. It needs multidisciplinary input. It needs a graded return response. And we need to continually monitor and record our progress so that we can gain some insights for future research. And I think what's important is that a lot of the manifestations of COVID-19 will mirror those of other infections. And so the medical implications should really be for all infections and epidemics and a learning process going forward, because this won't be the last pandemic. So if we look at a sports person's medical condition, they could fall into any one of these 4 categories. They could be asymptomatic, and in being asymptomatic, they could be COVID negative or COVID positive, or they could be symptomatic, okay, and if they're symptomatic, they could still be COVID negative, in other words, the causes come from something else, or COVID positive. And the symptomatic, in turn, could also be mild, moderate, or severe. And so we've got different scenarios that we need to be able to work through. So how do we do that? So there's a process that we go through. The first is a screening process. So as we reintegrate athletes, we need to screen them every single day. And you're aware of how we do that. It can either be a pencil and paper process, but there are increasingly some very nice apps available. This is one that we use that's South African design, and it's really an excellent one, Test for COVID. And it monitors the history, the symptoms, and potential exposure to COVID-19. And that needs to be done really frequently. We then need to have our athletes undergo a thorough baseline investigation, medical assessment before they re-enter this process of returning to sport. And particularly those who are symptomatic later on will undergo follow-up examinations. But that baseline examination is important in terms of determining their health before they restart the sport reintegration process. As part of the investigations, a baseline ECG, resting ECG, and spirometry are very useful in terms of determining the baseline data for those particular individuals. And then we should know what their COVID-19 status is in terms of a PCR test before they enter. Certainly if they're symptomatic and there's suggestions that they may have contracted the condition. And then repeatedly, how often that should be is going to be dependent largely on cost. It would be lovely to test everybody every week and know where they are, but that's not always possible. But that testing is available and needs to be utilized. And then the final aspect is a graded submaximal exercise test to ease them back into exercise and into training, particularly if they have been ill. I'm going to emphasize this, which is becoming more prominent in the medical literature, and that's the fact that this is more than just a respiratory disease. And it's more than just a respiratory disease because the ACE2 receptor is to be found on numerous different tissues. So it manifests around the body, and as a result, the SARS-CoV-2 adheres to that through that spike glycoprotein and can cause conditions as widespread as diabetes mellitus and neurological conditions. And we're all aware of the risks of thrombosis as well. So it's very important to keep a very broad index of suspicion in terms of the types of conditions that might manifest. They might be neurological, they might well be just respiratory. But that comes about both as a result of the viral infection, and as we indicated when we spoke about the immune system, the body's immune response as well, which that cytokine storm might also cause some of the range of symptoms and signs that we may encounter. So in closing, I want to look at a quite comprehensive flow diagram approach to athletes with acute respiratory infection, as most of these patients will be. And this I credit my colleague, a South African colleague, Professor Martin Schwellnus, who kindly allowed me to use this because I think it summarizes the key aspects very well. And if we have an athlete who has been exposed, we need to really follow a very thorough and stepwise process that starts with a good history and assessment of the severity. As I mentioned, they may be asymptomatic, or they may have moderate or severe symptoms. And if they're asymptomatic, you track them down the left side there, and it's important to undergo that comprehensive clinical assessment and monitor their progress. And if they have residual symptoms, allow those to settle. Once they become asymptomatic, to then perform a graded submaximal exercise test to make sure that those symptoms don't manifest when they start exercising again. Those that have more severe manifestations need to be more significantly worked up, followed up with resting and exercise ECGs and possibly even echocardiograms, a range of blood tests to look for multiple organ involvement, pulmonary investigations in the form of chest x-rays, spirometry, pre and post exercise, and possibly even a CT chest. And then the multidisciplinary approach, perhaps looking at vascular, neurological, and musculoskeletal consultations as well. And only once those have been found to be normal and they're asymptomatic, can they move towards that graded submaximal exercise test. In terms of how long to isolate them and the return to sport, these are the latest sort of guidelines in terms of general population, that you should be isolating for 10 days after the onset of symptoms if you have mild disease. And for those who have been hospitalized or have moderate or severe disease, for 10 days after those symptoms resolve and you've reached clinical stability. For asymptomatic patients, for 10 days after your test came back as positive. For athletes, it's a slightly more complicated scenario, and this is a table that summarizes how long you wait before returning to sport in terms of those who are PCR positive and those who are PCR negative. And so if you're PCR positive but have no symptoms, you isolate for 7 days, ideally retest on day 7, have your family and household isolate for 14 days, and then look at contact tracing. You're not usually necessarily isolating the team, and the doctor needs to monitor the situation in each of those groups. If you are PCR positive and symptoms are absent but then start developing, you isolate after the test results and until symptoms resolve for a minimum of 7 days. Retest a couple of days after those symptoms resolve, and then start controlled activity for 7 days following a negative test, and then only after that reintegrate into a team environment. For those who are PCR negative and have symptoms, I think importantly to treat them as if they do have a viral infection, isolate them for 7 days or until symptoms resolve, retest to see that there wasn't a false negative test, and then also look at isolating family and household members. If the retest is positive, then they need to follow the guidelines for the PCR positive. If they are obviously asymptomatic with a negative test, there's no action to be taken. They can be reintegrated. That's just a summary of the options available to clinicians. Other implications which we need to consider all the time and moving forward: hygiene. Don't need to emphasize that. We all know the issues around hand washing, sanitizer use, masks, not sharing water bottles, and being careful with travel. And I think going forward, those are going to stay with us. Very importantly, what's happened to drug testing over this period? Has it been a lull period that's allowed for people to take performance-enhancing drugs? And perhaps that's something we need to consider. This concept of distancing and isolation, I think in a team and crowd environment, is something that we will carry forward and try and avoid as much as possible because of the risks of transmission. And then very importantly, trying to boost research into this area. We know there's a lot of research going into vaccines, but how can we be better prepared the next time such a pandemic approaches? So I'm going to wrap up here by concluding and summarizing the main points. The first is that exercise is always appropriate. Unless you're sick, it's exercise is beneficial in all people, nearly all situations and at all times, especially in the vulnerable and those who potentially could be exposed to the virus. You need to be protected by having a boosted immune system. And I think over time, we've probably underestimated the effects of regular exercise on the immune system. We've learned that exercise protects against non-communicable and communicable diseases, and we therefore need as clinicians to facilitate exercise and sport responsibly in the environment in which we're in. We've learned that COVID-19 is a multiple organ disease. It requires multidisciplinary input, graduated return to play program, ongoing monitoring, and a lot of research before we fully understand the condition. So I'm going to wrap up there by saying thank you very much for your attention, and certainly if there are questions that come through the course of the afternoon, I'll be glad to take them.
Thank you, John, for your excellent lecture. It was very informative. We have some questions to you. If you could stay back for a few minutes.
Sure.
Before that, I would like to request Professor Arumugam, the President of Indian Association of Sports Medicine, to give his talk. And meanwhile, we'll take this opportunity to welcome two key persons of the Malaysian Association of Sports Medicine, Dr. Kinchan and Associate Professor Dr. Abdul Halim Mukhtar, who's the current President of the Malaysian Association of Sports Medicine. I think he is there. So we welcome you both to this webinar series, and thank you for your kind cooperation. And over to Dr. Arumugam, sir.
Good afternoon to our esteemed colleagues from Malaysia. And I take this opportunity for, on behalf of the IASM, for thanking all your efforts to make this webinar really come true. And I hope to have similar collaboration in the future. So Professor Sandhu is supposed to give a lecture on evolution of sports medicine. Due to unavoidable circumstances, you're not able to come. So I'm going to give a small talk on sports science in India, challenges and scopes, which will also cover many of what we need to know about what is happening in India. So we all know, India's performance at the international level is not very encouraging, and Olympic medals so far we have only 26 medals. But Government of India also recognized this, and they've taken really revolutionary steps in correcting this status. And during this lecture, I'll go over what are those steps taken by our government as well as some private agencies. And today's scenario in sports in India is really grown exponentially, thanks to the various Premier League, starting with cricket, going into football and badminton, kabaddi, and so forth. What is needed for India right now is a foundation for scientific assessment and enhancement of sports. So also we recognize not only a good infrastructure for every athlete, 1,000 athletes. There are so many supportive staffs we need in India. Right now we are getting some exports from international arena, but government recognized as well as some private universities, most notably our own Sri Ramachandra University, taken initiation in this field and started the state-of-the-art Center for Sports Science, where the very good infrastructure along with various sports education program started. So the world-class sports facility was set up with Professor Tim Noakes as a mentor. And this is a small glimpse of the facility we have, about 100,000 square foot, fully air-conditioned facility, and indoor stadium, indoor arena, high-performance center, an advanced fitness center, and the various sporting arena, and then outdoor practice area, where the swimming pool, temperature control, and hydrotherapy, isokinetic lab, and the exercise physiology lab, various types, and the sports predator assessment, high altitude chamber, the biomechanical lab, one of its kind in this part of the world, and it is meant for this one got 20 icon camera for cricket. The same thing can be used for other sports. And more importantly, we have international experts in various fields. As you can see, Dr. John Patricio is one of the faculty on our expert panel. And this is a team what we have at Center for Sports Science. And now Government of India also recognized the need for this kind of facility. Recently announced there will be 8 Center of Excellence, similar to what we have in 8 corners of India. Each will have the state-of-the-art sports science labs, and our center has a comprehensive athletic assessment as they do in Western world. And similar things will be launched in other centers also. And we also realized sports education. This has gone to a big evolution there. And we started MD Sports Medicine for the first time in India. Not only MD Sports Medicine, also various sports science courses. We started BSc Sports and Exercise Science along with the University of Cape Town. Now this year we are launching MSc in the sports psychology as well as MPT sports physiotherapy, and we'll be launching similar courses in sports biomechanics and sport nutrition. We're entering into collaboration with various universities in the UK and United Kingdom, and Government of India also through its sports education unit at Patiala and Sports Authority of India. They are kind of looking forward to tying up with the various universities, including ours, to launch similar master's program as well as degree online certificate course program. People who already in the master program, just to freshen up and to update with what's going on in the current scenario in the sports world. They are going to launch the online certificate course, and I'm proud to announce that they're tied up with our university to launch 2 such courses very soon. That's in sports nutrition and sports physiotherapy. It's an online course, but also there will be a every 4th week or 6th week, there will be a in real contact, and there will be a the end of 6 weeks there will be theory exam as well as the practical exam. And various research are going on in our lab. And so this is a comprehensive services what we do, our Center for Sports Science, not only the sports medicine services, also sports related services like strength and conditioning and sports education. So we have one Center of Excellence by Government of India 5 years ago. And also the ICC, International Council, recognized our biomechanical lab as one of the 5 labs in the world to check the suspect bowling action. And not only suspect bowling action, we also do a lot of research, especially in the fast bowling, the prevention of injuries, and our one PhD paper was accepted for international publication. And we're collaborating with BCCI in India to carry on this research. So similarly, in other part of the sports, we have launched latest FIFA standard football turf, and a lot of football medicine related research work has been going on along with the Government of India initiatives. and football biomechanics is another area, and Asian Federation has recognized as the first center of excellence in football medicine in India, our center. And Chennai FC, one of the ISL teams, which has won 2 times the ISL championship, is housed in and partnered with our center for the sports medicine and rehab. Also, we are doing a lot of work in rowing, because the government of India recognized top 10 sports, and rowing is one of the sports where there's a potential for medals. And this is an indoor and outdoor rowing facility in our own university. We have a 3D motion capture analysis for the rowing, also tied up with the BAT logic. We've done a lot of work on the ergometer based and as well as water based study on the foot biomechanics, rowing biomechanics. Similarly, we launched a Center of Excellence in Shooting along with Gagan Naran, who is the Olympic medalist in the shooting and basketball. And most recently, we launched a hockey turf along with Olympic gold champion Dr. Bhaskaran as a mentor on for the hockey academy. And the small video I'm going to share.
12 വർഷം മുമ്പ് എനിക്ക് വെള്ളം പേടിയായിരുന്നു, പക്ഷെ ആ പേടി എന്നെ തടഞ്ഞില്ല. ഒരു നാഷണൽ ചാമ്പ്യൻ ആകാൻ വേണ്ടി മണിക്കൂറുകളോളം ബോട്ടിലും ജിമ്മിലും എനിക്ക് കഠിനമായി പരിശീലിക്കേണ്ടി വന്നു. മത്സരത്തിൽ ഓരോ മില്ലി സെക്കൻഡും വിലപ്പെട്ടതാണ്. ഇനിയും മുന്നോട്ട് പോകാൻ എനിക്ക് ശാസ്ത്രീയ പരിശീലനമാണ് വേണ്ടത്. എന്റെ ടെക്നിക് ഇംപ്രൂവ് ചെയ്യാനും എന്റെ ശാരീരിക ക്ഷമതയുടെ പരിധി വർദ്ധിപ്പിക്കുവാനും ഓരോ സ്ട്രോക്കിന്റെ വേഗത കൂട്ടുവാനും ശാസ്ത്രീയ പരിശീലനം എന്നെ സഹായിക്കും. I am ready, India, ready to win.
This is what we do at our center, and the Indian Olympic rovers undergoing rehabilitation at our center, and the various champions in different sports like sailing and shooting who got trained at our center. And Bhavani Devi is a fencer, first Indian woman to have an Asian gold medal, and these are the bronze medal winner by sailing. And other important landmark scheme by Government of India is Khelo India. So where government is recognized, we needs about 8 or 10 years for preparing athletes for Olympics. So come up with the innovative program where they pick up the children, about 1,000 of them, the age of 13 to 14, and they put them in the residential academies all over the country. And each student will get about 6 lakh rupees for his training as well as education. And our center about 4 such academies, and I think this will really change the way how we're going to perform in forthcoming Olympics. And so it is really the sports revolution is happening now, and this is the right time for anybody who want to be in sports medicine, because the government of India is coming up with various programs, as well as I mentioned, 8 center of excellence across the country. They're opening up various job opportunities in the area of sports scientists, like exercise and strength and conditioning, physiotherapists, sports psychologists, sport nutritionists. Also, they're offering new courses. So this is the right time for anybody who want to be serious in sports medicine to venture into. And thank you for the opportunity.
Thank you, sir. Thanks for the very invigorating and inspirational presentation. And since Dr. John has finished his talk, we have some questions. So we'll quickly go to the questions. I'll share the screen with the questions. Dr. John, of course, these questions are so anticipated, and wide variety of questions, in fact. The first thing that normally people ask us, should we wear mask while performing exercises outdoor? What are the merits, demerits? I think you have covered inside your presentation itself, but still, if you could slightly elaborate more.
I think we've got to try and mitigate risk in whichever way we can. And so wearing a mask is certainly one way of doing that, and it will help protect those around you. And I think I really say wear a mask whenever possible. During intense exercise where breathing becomes difficult, it might become very, very difficult to wear a mask, but then I think you should isolate yourself and exercise in your own environment if that's the case. But wherever possible, I think you should be wearing a mask when there are others around you.
Thank you, John. And India is a country where we practice a lot of Indian medicine, claiming to have immunity boosting powers, whether they are foods or supplements or some hot drinks. So do you have any recommendations or experience or on these things, immunity boosting food?
I don't think there's anything that's been shown to be absolutely beneficial in COVID-19. There's some evidence that zinc might be beneficial, but certainly I would go back to advocating a good, healthy diet and regular exercise as the main immune boosters. If there is a deficiency in something, or you don't take a particular food type, so if you're a vegetarian, for instance, you might want to supplement with iron. But I wouldn't advocate one or more specific supplements. I think just general good eating, regular exercise, perhaps you might want to consider things like vitamin D and zinc as a possible supplements. They certainly won't do any harm, and that may be of some benefit, but you can't rely on them.
Thank you. I think we have many more interesting webinars coming up in sports nutrition, and some experts are there to give their inputs also. The third question is, will a change of environment pose threat to safety?
Yeah, it's a broad question. So it depends very much on what that environment is. So let's take indoor versus outdoor, for instance. So your indoor environment, particularly if it's poorly ventilated, will certainly increase the risk. Exercising outdoors is going to be safer. Then you can look at summer versus winter, climate type conditions. I think in a winter type of environment, the virus tends to thrive more and people tend to be closer together, so the risk of spreading is greater. So any environment where there are people together indoors is going to be a high risk environment.
Excellent, thank you. And probably we can combine the last two questions into one. What is after COVID, return to new normal with the return to sports? After such a prolonged period of detraining, is it going to cause injuries more, or high performance competition can we resume? So please advise on that.
So we absolutely want to resume, and that's a very good point, that one of the risks and one of the considerations has to be, after a long layoff of not being able to do sport-specific training, what are the risks of injury? And they are going to be higher, and so it needs to be a graduated approach. We can't suddenly end lockdown and start professional sport again. There needs to be a graduated approach, increasing intensity and becoming more sport-specific and more intense over a period of weeks. And the longer one's been out, the longer that build-up has to be. So I think anything more than 2 weeks out of sport needs a graduated reintroduction. Otherwise, the risk of musculoskeletal injury is certainly higher.
Okay. With that, I think we can conclude. There are a lot more questions, but I think we'll conclude with this. And thank you so much, John, for being with us, for all your valuable time. Hope to see you in our future webinars also. So if you are free, please feel free to stay with us for the next 2 talks.
Welcome. Thank you very much for inviting me.
Thank you. So I would now give a brief about this special webinar series, which is rightly termed as Return to the New Normal. It's a sports medicine and science sans frontier. That is, we are going to break all the barriers of geographical barriers. So we are going to collaborate and have a Asian level and international level of collaborations. So as Professor Arumugam sir, the president of IASM mentioned, it's spread over 8 days with 31 lectures with 12 countries, faculties participating, and organized by IASM in collaboration with Malaysian Association of Sports Medicine, accredited by the Asian Federation of Sports Medicine. We have a beautiful program lined up for you for 4 weeks, including sports surgery, sports medicine, sports nutrition, and all topics covered together. So please, we'll all circulate this widely. And talking about Asian Federation of Sports Medicine, we have its Vice President, Dr. Kim Chan, here. Sir, welcome, sir. And we would request you to give your opinion and talk about this collaborations proposals.
Hi, everybody. Thank you for the invitation, and I'm very privileged that we've been able to collaborate with IASM. AFSM is also very much involved in this because I'm actually in charge of the ASEAN countries, and we've been trying to get the whole group together, and hopefully they're all online and benefit from this great program. And it's been a great opportunity, and I hope that we get to collaborate more in the future on this sort of thing, which is, I think, very cost-effective way under the circumstances and over transcontinental areas and time zones and all that. And it's a lot more economical way of teaching and understanding and learning as well. And thank you again, Dr. Arumugam. Great to see you there. And thank you again, Thiagarajan, for organizing all this and all the hard work that you put in. And it's been a great pleasure. And we'll carry on with the program. And thank you again for the opportunity.
Thank you, sir. Thank you for a kind word of encouragement and support. Looking forward to work closely with you in the future. Thank you again.
Great.
Thank you, Dr. Chan. And if Dr. Halim is there, may I request him to come online, please?
Hi, Dr. Tega. Can you hear me?
Yes, but your video, we are not able to see you.
Right. Can you hear me again? Sorry. But...
We can hear you well, but we're not able to see you.
Ah, okay. So let me try this out again, yeah? Can you see me?
I think your video is on facing your slide, your computer. You have to change it to your face. Yeah, now it's better. No, yeah.
Hi. So
hello.
Let me see.
And now we can see you well.
You can. Thanks.
So welcome, Dr. Abdul Halim Mukhtar, the current president of the Malaysian Association of Sports Medicine, and the stage is yours.
Thank you, Dr. Tega. I have to ask you, Dr. Tega, to help me out with the presentation. Just move my slides for me because I have some technical issues here. Can you do that?
Okay, we'll present your slides. I think Professor Mahendran has sent your slides.
Okay. While waiting for the slides to be uploaded.
Okay, meanwhile, you guys please talk about the Malaysian Association of Sports Medicine till I fish out your slides, please.
I would like to thank the Indian Association of Sports Medicine for inviting us to collaborate in this webinar. I think you guys are doing a very wonderful job. I would like to congratulate Professor Arumugam Dr. Tega and your team for organizing such a great webinar and conference. Yeah, it is true that during these tough times, we can still meet up, but and confer online, and this is wonderful. Despite with all this COVID-19 restriction of travel and all that, so I'm glad that we can actually do some collaboration. A little bit on the Malaysian Association of Sports Medicine is actually an association established in 1970s, and we have about 500 members now. And they range from doctors, physiotherapists, nutritionists, sports scientists, and many other who have interest in sports medicine and sports science. And they are actually on board. And I can say that in the last few years, the numbers of membership and interests have actually grown. We have conducted quite a number of conferences, and the last two, I believe, Dr. Tega were there as well. Yeah, and we wanted to do one this year, but due to the COVID-19, we had to postpone that to next year. Hopefully, everything settles down and we can have face-to-face conference rather than just webinar. Yep, I would say that that would be from the Malaysian Association of Sports Medicine. We hope to actually work further with you guys with you, Indian Association of Sports Medicine, and perhaps we're gonna organize our own webinar, and we'll invite you guys to join in and collaborate with us. Thank you, Dr. Tega.
Thank you, Dr. Halim, for sharing your time, and it's really a wonderful, maybe one of the opportunities of what COVID has given us. Otherwise, we wouldn't have entered into that. So always a good thing to, that's how we look at it. And as Dr. Chan mentioned, we're looking forward to more Asian country collaboration and more similar webinars in the future. So Dr. Tyagarajan, if everything ready, we can go for next lecture.
Yes, sir, we are ready with Dr. Halim's slides. I will just project it in a minute.
All right, thank you, Dr. Tega.
Yep.
Good afternoon, everyone. Well, that is at least in Malaysia now. I believe it's still there, the same thing there in India. So good afternoon, and my title of presentation is on arthritis in athletes. I was actually cautioned not to talk too much on COVID-19. There's so many of COVID-19 lectures going on. So that's why I move away from that. Thanks to Dr. Mayan for reminding me on that. So we will actually go through a topic which is dear to me, which is arthritis in athletes. Next, please. Okay, when you have a painful and swollen joints in athletes, we wonder what are the causes or what is the cause of this? And usually there are several questions that come into our mind. Number one is actually, what is the age of onset of this osteoarthritis? Is it during childhood? Is it actually adult? Is this actually during their elderly years? And we also we need to actually ask or ponder the chronicity of the pain and swelling. And what joints are affected, and whether there are general symptoms which are involved. It's not just about the joint, it's also about generally whether there's fever, for example, malaise or what. And then, of course, one common questions that we usually ask and we usually jump into is actually whether this joint pain or swelling is related to trauma or to sports. And this is one of the reasons why we sometimes actually miss other causes of actually arthritis in athletes. We should also look at perhaps there are other organs involvements and whether there are other diseases. Family history is very important in some of these diseases of the joints, and medication history, which sometimes may actually, some medications can actually cause some of the arthritis. Next, please. Now, it is trauma related. This is usually monoarticular, so it's a single joint, and this is the usual or the most common thing that we would suspect. If it is from the athlete, then it should be trauma related. Well, it is true though that in somewhat most of the cases that present to us, they are related sports injuries. So injury to the internal structure, for example, the meniscus, the cartilage ligament may lead to hemarthrosis, for example, and this would actually give you an inflammatory arthritis. Or the structure itself directly may be pain sensitive, and they can actually give you all these symptoms and signs. And the main issue, of course, here is actually the trauma itself. So, and if you look at it, the management of this would actually depend. If the basic management usually is all the same, it would be the acute management, which consists of price, protection, rest, ice, compression, elevation. But when it comes to definitive management, it all depends on the final diagnosis. For example, if it's the ACL complete tear, then probably an ACL recon would be the answer to that. And one thing that sometimes it is related to trauma, but it may be a trivial trauma. So here we need to suspect something else. For example, maybe there is a bleeding tendency problem. For example, in this case, is an anticoagulant or vitamin K deficiency or other clotting factors deficiency. Next, please. If it is again monoarticular arthritis, this is one of the common thing that may present to us, and they sometimes can be preceded by trauma. It's just that we need to be more inquisitive, especially if it comes from a male, age between 30, 40, despite them being athlete, and they may actually suffer from actually acute gouty arthritis. And sometimes it's actually pseudo gout, although I will actually discuss to you that the typical presentation of pseudo gout later in the next slide. So it's for gouty arthritis is actually caused by uric acid crystal deposition, and they, as I say, may be preceded by trauma or sports activities, and other risk factors include genetic. If, for example, in the family there is someone who's got gout, then that's very likely that you may get gouty arthritis as well. Obesity and dyslipidemia are both related to gouty arthritis. Now, dehydration, which is actually common in sports, and sometimes an intentional dehydration, or it's just actually we were just not looking after our fluid and all that, and dehydration itself can actually predispose to gouty arthritis. And of course, certain food and certain drugs, for example, certain antihypertensive drugs, diazides, for example, phosphotiazides, that may actually, or furosemide, for example, may actually cause or predispose to gouty arthritis. Next slide. Now, in pseudo gout, it is actually not similar to the presentation of gouty arthritis, but they are both crystal arthritis. So what differs between them is actually pseudo gout is more common in the elderly and female, and it's just that it can still happen in younger age, but more common is actually in the elderly age group. They have several features which actually not similar to gout, and the common one is actually the chondrocalcinosis, which is actually calcification seen in, for example, fibrocartilage or meniscus. These are the areas, even the cartilage. Sometimes they get calcified in pseudogouty arthritis. To defer them both can be difficult because acute gout and acute pseudogout arthritis, they are very similar. So synovial fluid analysis is usually helps us in actually determining whether it's actually gout or pseudogout. And although this is not really required in many cases, with the clinical suspicion, as what we see just now, probably would have helped us in most cases. Next, please. Oh, this is not to be missed. Septic arthritis, they usually come in toxic looking, high fever. So if an athlete presents to you with all these general symptoms, like very feverish, so we should actually rule out septic arthritis. And the in those who have had instrument in their joints or in their bones, sometimes can actually predisposed to this. For example, those who have actually gone through prosthetic hip or knee joint. And those who are actually having certain other diseases may actually be predisposed to septic arthritis. Now, it is from our joint injections, which we sometimes do give. It is rare, although it can still happen. Especially nowadays, it's very rare because of our aseptic technique. The causative organism for septic arthritis, the first one is actually Staph aureus, and followed by Streptococcus species. Of all this, I would like to actually highlight, just to let you know that knee and hip are the more common one that is actually get infected, followed by shoulder and ankle, and they are commonly monoarticular. And the presentation is usually high fever, very painful, plain joint. Thanks. Next, please. One slide earlier. Okay, this one. Another part of septic arthritis is gonococcal arthritis. This is not as bad or as severe as the one Staph aureus arthritis in terms of presentation, but we need to suspect this, especially in young, healthy, and sexually active individuals. Commonly, this is part of a disseminated infection rather than the joint itself. So the joint presentation could be migratory arthralgias, but majority of them would have some classic skin lesions. And the joints are predicted to have gonococcal arthritis infection, usually the fingers, wrists, elbows, knees, and ankle. So you can suspect that, although it can be oligoarticular, which means single, it can also be polyarticular. But then they can be migratory, can be asymmetrical as well. Next, please. Now, one which is actually not so common yet, sometimes baffle is when we have an arthritis, which is sterile, right? But it's actually related to other infection, which is extra-articular. The common association is with the gastrointestinal infection of Shigella, Salmonella, Campylobacter species. And in fact, I think the more common one would be the genitourinary infection of Chlamydia trachomatis. And this is actually non-infectious, and usually are coupled with usually they have non-infectious urethritis, and coupled with arthritis and conjunctivitis as well. So for this one, we need to actually work out the urine stool and look for the organism. And the common ones, if you actually treat them, usually the symptoms will subside as well. Thanks. Next, please. Rheumatoid arthritis, so the age onset is about 35 to 50. These are the common ones, although they can happen at early age and may happen in the athletic group. So just be on the watch out. We are not sure, or we do not know the actual cause, although autoimmune, genetic, hormonal, environmental, tobacco has been linked to rheumatoid arthritis. So the pathology includes inflammation of the synovium, and then if this is actually prolonged and not actually intervene, will result in irreversible destruction of the synovium. Okay, the typical history is actually chronic inflammation with intermittent acute exacerbation. Usually it's insidious onset with joint pain, swelling, and morning stiffness. And the more common joints which are affected are the hands and feet, small joints of the hands and feet. Nevertheless, they can actually occur in shoulders, elbows, knees, and ankles as well. But the common pathognomony will be they are symmetrical, and occasionally they are, they can also be monoarticular, but usually they are polyarticular. Next, please. Now, if we have someone that we think it's rheumatoid arthritis, we should refer them to the rheumatologist because they need to be managed early by the rheumatologist. In my clinic, I've seen several cases of such. And once the diagnosis and treatment has been started by the rheumatologist, I usually co-treat this the case, and so we will actually talk about managing their exercise, physical activity, and all that, because exercise has been shown to actually improve the quality of life of those with rheumatoid arthritis. So I wouldn't actually go so detailed on the treatment, but just notice that when we actually treat and manage them, just be alert of the other medications that he's on. For example, the biologic demands, they may increase the risk of infection in these cases. And the rest of them probably require somewhat similar to, similar question. And just remember that prolonged use NSAIDs can result in other side effects as well. Next, please. Okay, this is on juvenile idiopathic arthritis. Can you move on the previous slide, please? Did we miss something? Okay. It's also unknown etiology. Usually it happens in the young children, age less than 16 years. Knee and the hip are commonly affected. So they may come to you as if they have got, I had an experience. One case that came to me at the age of 16, who came with actually joint pain, with trivial sports trauma, and he thought it was because of the trauma, but it came out to be actually a juvenile idiopathic arthritis later on. So, so you suspect when they are less than 16 years, there's no history of trauma there, and the symptoms usually are prolonged. The symmetrical, usually they are asymmetrical. They can be symmetrical, polyarticular, but can also be oligoarticular, which what we usually see actually. And then this particular part where enthesitis related arthritis can actually again mislead us to thinking that it's actually sports injury. So just be on the watch out for that one. Sacroiliitis is not uncommon here in GIA. And also look for other systemic presentations like uveitis, psoriasis, which may actually help in the diagnosis. Next, please. Okay, if you have one that you suspect, we should actually refer to either PIDS or PIDS rheumatologist early. Although NSAIDs is one of the main treatment that we use. But other DMARDs and other biologic and non-biologic use of DMARDs, right? DMARDs, biologic and non-biologic have been used as well to treat. So in our role as a sports physician, we usually assist in the physical activity component. Our GIA patients tend to have lower muscle strength, aerobic and anaerobic fitness, so we build on this. So it's just that just be careful when we actually prescribe exercise. Just make sure that they don't have anything that could have suggested pericarditis and myocarditis, because they may get this complication as well, and this can be life-threatening if you do if they involve on exercise. Next, please. SLE or systemic lupus erythematosus. This is a chronic multi-system autoimmune disease. Nearly all joints can be affected. The hand and the knee are the typical joints affected. The next part, the next thing about this is that tenosynovitis, tendonitis, tendinopathy may also occur as well. And it may also result in avascular necrosis of the hip and the knee. Here, 90% of the cases, they are women, and the classic presentation, although this classic is no, we don't really see them all the time. If it's fever, rash, which is usually called a butterfly rash or a mala rash, in women of childbearing age, these are the common, the classical presentation, right? You can see them not in this classical presentation. Family history of autoimmune disease should raise the suspicion of someone having SLE. Next. Sorry, the slides, I can't show you that how SLE has actually multi-system stroke organ being affected as well, involvement. Next, please. Okay, in general, if someone has SLE, once they have established this, then we should actually help them in terms of getting back to exercise. And again, these are all about physical activity. SLEV will actually usually results in reduced muscle strength, low functional performance, and quality of life, and greater fatigue. So our physical exercise may help them to improve all this. Again, likewise with other inflammatory arthritis or medication, just look at the medications because they have got a long list of side effects. So when we prescribe exercise and we monitor them, we should also look at whether they've got all the other side effects. Yeah? And the questions on NSAIDs for this, as if I talk about rheumatoid arthritis, I was actually talking about more so in terms of the side effect of gastrointestinal hemorrhage. But for lupus or SLE, they are notorious to have hypertension and lupus nephritis. So NSAIDs may actually further damage these organs. Okay, well, can you skip this, please? Ankylosing spondylitis. Now, this is the few, like RA. Ankylosing spondylitis is among other, say, inflammatory arthritis that I've actually come across coming to my sports clinic. And these are young people, male, very active, age about 20 to 30. I mean, one I saw last time was actually very active. He was even a weightlifter. He complains of actually low back pain. And this is a common presentation of them. But they also have morning stiffness, night pain, which the typical part of the pain is that they improve with exercise, but does not improve with rest. So in most mechanical back pain, they usually get better with rest. But in this case, ankylosing spondylitis, they actually got worse with rest. And these are the let's just say the hints, the cue for us to suspect ankylosing spondylitis. Just remember that sacroiliitis, dactylitis, and ascites are also common, and HLA-B27 positivity has been linked to ankylosing spondylitis. Next, please. All right, should someone with ankylosing spondylitis be exercising? Should we actually get them to exercise? Yes, definitely we should, because they do help, the exercise does help them. And for the spine, it increases the spine mobility and physical function. And for those who actually have not been using, because of, have not been moving because of the pain, then they may get osteoporosis. So the exercise that we prescribe may actually, let's aim towards that, against osteoporosis, protective against osteoporosis. Then pharmacologic management together with exercise have been shown to actually help synergistically in terms of treating the ankylosing spondylitis patient. Next, please. Osteoarthritis. Now, osteoarthritis, although we usually think of it as actually the disease of an elderly or more advanced age, but it can also happen in the younger ones. The pathology of OA usually involve destruction or inflammation of the bones, synovium, joint capsules. So it's actually the whole system, the whole joint. But the main ones is actually in the articular cartilage. Then joint degeneration occurs following all this inflammation, chronic inflammation, and the articular cartilage damage ensued, followed. Sports, because in sports, direct injury to the joints and all that may actually add on trauma to the cartilage or to the joint, which actually may predispose to OA. Maybe, we'll actually have to look through some studies which have actually been done. So there is actually a theory that in athlete, the higher rate of loading and the frequency of impact increases the amount of disruption and damage to joint cartilage. Whereas the slow loading, which means that our walk, our common functional daily activity, that allows better fluid distribution and does not actually cause stress to the cartilage. But if faster loading and impact during sports activities, they seem to actually be not helpful or maybe deterrent to the joint cartilage. Nevertheless, there are contradictory comments, because if at the same time we say everyone should exercise. So plus and minus, we have to actually look at this particular dose we call, good to exercise, and the other one who's actually overdoing that with the exercise, which may contribute to development of osteoarthritis. And that's this particular part where we have established that obesity is linked to osteoarthritis, at least in the elderly. But in athletes, although, obesity can happen, but high BMI, for example, in someone with high muscular bulk and all that, whether that can actually predispose to osteoarthritis as well remains contested. So because the bigger bulk, or despite being heavy, it also helps in joint stability and in general joint health. Okay, next, please. Right. There are some challenges in diagnosing osteoarthritis in young athletes, but the common notion is that the common notion is that OE is the result of wear and tear and joint injury, which is common in sports. Have been thought to be actually associated with OE. But the classical symptoms of OE, like joint pain and stiffness, usually refers to less than 60 minutes. That's more than that, or usually more than 60 minutes. That's refers to inflammatory joint arthritis. So less than 30 minutes joint stiffness actually is the classic symptoms. But the athletes may disregard this, as they assume that this joint pain and this mild stiffness may be normal or acceptable in their sports. So, and coupled with the desire to return to play, this all may actually mask the OA pain, the symptoms, right? To add on to that, the plain radiograph, if you at an early stage, which is the common the common stage where the athlete is found at, may not be helpful in the early stage. In fact, some cases, and to add on to that further, is that some cases of structural OA, like you find osteophytes there or reduced joint space, they don't really have the symptoms. So sometimes what I'm saying is that sometimes there are findings in the X-ray, but you cannot specifically call that osteoarthritis as well. So there are some challenges there. Okay, there have been several studies that look into this question, whether OE is high in athletes or not. So one of it is actually looking at the 20 former elite marathon runners and compared to the non-sports population. As for gender, age, and BMI, they concluded that there was no increase of risk of OE in these former runners. And there's another systematic review by Salsky et al. That showed some evidence of relationship between long-term exposure to heavy lifting, standing at work, and risk of hip OE. So for this one, let's see if there is some relationships. Next, please. And there are other studies as well that look at this. The sports participation, including level of performance, previous injury, increase the risk of OE. Next one, please. And this participation in certain sports associated with knee OE, systematic review. The next slide, please. Let's say that in this case, I have to actually adjust that a bit. Okay, sorry. Can you just look at it? Yeah. Okay, I can't really see it here, but mainly I would like to say that in some sports, it seems that there is higher risk of OE, and these are like soccer, elite, long distance running, where we believe there is a bit of thanks, when there is more impact on this on the joints, and this actually predispose to OA. Right, and then we can't apply though our notion to female and non-elite athletes. We need more studies on this one, and even recreational athletes. but contact and collision sports like elite football and soccer has some evidence to show that the increased risk of OA. Next, please. Right. When you talk about treatment in OA, whether it's we actually kind of like check whether this one is it different than the OA in the elderly or the more primary OA, for example. And right now, we do not really differ in terms of treatment. So the main goal of treatment is in athletes is to minimize pain and improve functionality. And when we talk about functionality, it's coming back to sports. That's critical to the athletes. So exercise is needed. Pharmacology may be needed sometimes. Bracing in some cases may help, and of course surgery may be needed. And that one would be, like debridement, etc. Okay. In summary, I would like to say that arthritis in athletes can be non-sports related. So we need to open our mind whenever we see someone with arthritis and inflamed joint. We should actually ask the questions that I actually put up in earlier on. What's the age? Was there any trauma? Whether there are other symptoms, the other organs are involved, whether there's any family history. So history helps to point to the diagnosis. And one thing for sure, subject arthritis must not be missed. And for inflammatory arthritis, although I did not discuss this in detail, but once you suspect inflammatory arthritis, we need to actually conduct further investigation to confirm that. And finally, I would say that osteoarthritis in young athletes should be considered as well in athletes who actually present to you with arthritis. Thank you very much. So that wraps up my presentation. Back to you, Dr. Jaga.
Thank you, Dr. Halim. So it was nice to get an overall complete view to revisit the arthritis aspects of the knee completely. So since we have consumed more time than allotted, so shall we go to the next talk by Dr. Bikram Karmakar from Australia. Dr. Bikram, if you're online, can you request you to share your screen, please? Before doing that, I'll have the pleasure of introducing Dr. Bikram Karmakar, who is a sports and exercise physician at Australia. And he had been to CSS when he traveled with the Australian cricket team to India as a sports physician. And he not only in cricket, he has got interest in multiple sports. And he would talk about a safety plan in COVID. Dr. Bikram, stage is yours.
Thank you, Dr. Kat, for the introduction. Yeah, I was very fortunate to come to Chennai and see the world-class facility at the Center of Sports Science. So today, I think what I talk about is actually applies probably to organizations like CSS, but also any level of sporting body, whether it's large or small. So what I'll be talking about today is how do we develop a safety plan for COVID-19, as we're sort of seeing increasingly that it's becoming more and more likely that COVID-19 is going to stay with us for in some capacity at least, and we're going to have to start developing this new normal. So I'll just bring up a little bit about myself. So Dr. Kat has mentioned already. So I do some work obviously with Cricket Australia, and I think coming back also to seeing how India is trying to increasingly have sports medicine, and a lot of perks with that type of job is that you do get to travel a fair bit. That photo in the top middle is at Wankhede Stadium this year. So it's Aaron Finch about to go in for a centre wicket practice. There's also other sports, as Dr. Kat mentioned, rugby league. This is with one of the Cronulla Sharks, which is a professional team in Australia. And then also being able to travel, something like this, which might have let me travel to India before, but of course we're doing it online, but being able to go to present and at different meetings and conferences. And then there's the other perks of travel, which is pleasure. And this is a photo which was not work related, but Adelaide Oval and India versus Pakistan. And it's one of my favorite photos, just the whole outlook and just being part of such an occasion. So John sort of mentioned previously about some of the worldwide rates. He didn't put up Australia's stats because by and large, Australia's done quite well if you look at international numbers. And New South Wales, which is where I'm based in Sydney specifically, We've had 49 deaths, and in Australia 116, which doesn't look like much compared to everywhere else in the world. Of course, our population is much less, but there has been slightly an increasing trend towards an increase in the rate of COVID-19 detection recently in the last couple of weeks, particularly in Melbourne, but also now in New South Wales as well. So this is sort of paralleling a little bit with the fact that we're trying to normalize and we're trying to increase activity and coming out of these sort of lockdowns, strict lockdowns that we've had, but we're trying to have some level of normal activity. So we've seen a slight rise, but we're also seeing, in countries like United States, Brazil, India, where, the numbers are so high, but at the same time, how long can you continue lockdown? And we need to have some level of normality within this. So if you look at it, there's a number of considerations that need to be taken, and they start with the athlete. And the photo I've actually put up, which continuing the sort of India-Australia link, is Mahesh here is actually a basketball player who's an Australian who actually played professionally in India. So there's another connection there for everyone. But yeah, for someone like Mahesh, but any athlete, there's a number of considerations that you have to make when we're incorporating the safety plan, which we'll go through. But the safety plan that you develop also has to incorporate the staff, the workplace itself, and of course, as we start to get more and more normal, and particularly with professional sports, there's a lot of travel involved, but also in domestic sports as well. And there's a lot of implications for the medical services as well, whether it's, from my perspective as a doctor, but also wider from that in terms of allied health considerations as well, and how we're managing different things and how we're managing athletes and staff as well. So in terms of the athlete, 4 main points that I've put in for developing a safety plan to try and get them back to that normal level of activity. And with anything, of course, the most important thing is education, and that education is what ensures an athlete's compliance to strict measures that they'll need to be taking. And that education is not simply, of course, coronavirus, COVID has been in the news, has been at the forefront for, pretty much the whole year. So, of course, there's a bit of the athlete feels drained, obviously, hearing this information, and coming to work or coming to a facility or coming to training, they want to let go a little bit. So it's very important that there is some consistent education that they receive. And one thing that happens, and, most people have sort of probably come across it, is that when you have something in the news for so long, people start developing their own theories. People have conspiracies, whether it's real or not. And so every athlete who's coming to a certain organization, they're coming from with different preconceived notions. So when they come to the facility or when they come to their training or they meet with their team, there needs to be some consistency in the education that's provided. And that education has to be evidence-based. It doesn't have to be as detailed as what we saw with John's presentation, but the message that's underlying in what he was saying and some of the measures that need to be taken have to be reinforced. And I think it's important actually to mention what John was saying before, is that despite the rates of coronavirus around the world, exercise is fundamental. It's both fundamental for the athlete's well-being, but it's also a tool in which we tackle coronavirus as well. So that also has to be part of the message as well. So the athlete needs to feel comfortable that coming back, being part of the sporting organization, is also in their best interest as well. But the education has to extend beyond measures of just telling them what coronavirus is, what it involves, how it's spread, the hygiene measures, but also we need to understand what their travel arrangements are, where are they coming from, who are they putting at risk, or are they putting themselves at risk in the way that they're traveling? And then when they go back home, what type of environment are they returning to? And if they're returning to an environment in which their family members or other people who they're going to be in contact with are also at risk of developing infection, then this is something that needs to be addressed so that we can provide them with measures to try and minimize or mitigate their risk as well. And again, something that John mentioned was regular assessment. And in a sporting facility or in a sporting team, that might be an electronic system. It might be someone who sees them prior to them entering, or someone that they can communicate with. And this needs to be daily. And that's particularly looking at their symptoms, any of respiratory infection, but also checking their temperature, and this needs to occur regularly. And I guess part with the education process as well, that you need to educate the athlete of the importance of recognizing the symptoms and the importance of reporting. And one thing that has been noted even in Australia, as we've seen sort of normalization, a lot of community sports have returned now, is that there's still a perception, just because it's been in the news for 6 months, definitely don't make the assumption that everyone understands the importance of it. There'll still be people returning to facilities, coming to gyms, coming to training, who might have minor respiratory, what they consider to be minor respiratory tract infections. It needs to be reinforced that those symptoms are actually important, and they're important to address, and they put other people at risk as well. Now, hygiene is very important, and athletes notoriously often don't necessarily have the greatest hygiene practices. So, this is probably something that needs to be reinforced at the best of times, but even more now. And sometimes for an athlete who, when they enter the training facility, their mindset might be set particularly on training. They'll do, they're focused on the training. They're trying to do as best as they can in the way they train. So you need to put it in their face. You need to have hand sanitizer accessible. You need to have, put signs up as you need to encourage good hygiene. And the other thing is, of course, changes to play. And we've seen recently last week, England versus West Indies returning to cricket. So, all avid cricket followers have been watching different rule changes. Can you shine the ball? No, you can't. We saw the two captains were shaking hands at the start of play. I mean, things like that, where, you're going to have to constantly reinforce particular messages. And of course, we'll come to the sort of travel and the more technical aspects of developing, frameworks and policy for those types of things, but it has to be a constant reinforcing. I mean, these are completely new, spheres that they're tackling at the moment. I think this is one thing which is very important is staff, and that staff, depending on, coming from a more professional sports organization, of course, that staff involves members of the team itself, whether it's the coaching staff, whether it's physio, trainers, biomechanical personnel, analysts as well, but also even within a training facility. And, coming to India, of course, somewhere like CSS, which is such a large facility, but you've got people, who are also, cleaning the area, who are working in cafes. Some people, open the door. Everyone is staff in that capacity. And all those people need to be incorporated as part of your safety plan. And one of the important things when you're returning to sport, and one of the things that needs to be considered, is how you arrange the staff, and particularly from a logistical standpoint. And some of the things now you have to consider is how many staff do you actually need. And in Australia and in other parts of the world, I mean, we've come up with terms like essential worker, and that doesn't necessarily put down the role of someone who's considered non-essential necessarily, but those are the people that you need to realize how are you planning to logistically arrange their staffing. And that includes things like, maybe you have to consider staggering start times. So not everyone starts at 8 o'clock, maybe they start at 10, 12. So you have less number of people in one room at a time. It could be that, people do more sort of shift works. It might be the situation where facilities are open longer so that you can disperse people over a longer period of time. One thing that, in physical distancing, one thing that happens with staffing is when you go to your workplace, if you've worked in a particular area for a long period of time, then it becomes almost like a second home. You let your guard down somewhat. And naturally, when we return to work, we go to the cafe, we see our colleagues or our friends, and we start talking to them. And when we forget about physical distancing, and we make this assumption sometimes that just because we're in the same workplace, that we are as one, and we don't share that same risk as someone we might see outside of the work sphere. But the reality is that most staff in most facilities are still returning to home. They're still engaging in transport or in contact with other people in the public. And so that risk is simply multiplying. So those physical distancing measures need to be reinforced even within an organization. And whether, it's a 1.5 meter rule, or whether you're, number of people in a room, number of people per square meter, however you want to measure it, there needs to be some degree of reinforcement which occurs consistently. And the longer this goes, the more likely is that people will become complacent when they return to work. Again, same with the athlete, there needs to be hygiene measures. This needs to be reinforced, whether it's hand sanitizer that's accessible, not just having hand sanitizer, but ensuring that they know how to sanitize it, you know, spending the time washing their hands, but also cleaning practices. And the staff, you know, one additional role that a lot of staff are now having to take, particularly in gymnasiums or sports training facilities, is that they have to take further responsibility of cleaning as well, regular cleaning. Every time someone uses the equipment, you know, it has to be wiped down. And this is something that is now part of their job role. So these are all changing, and so cleaning is very important. And yeah, I think early on when this was all coming out, I mean, gyms were one of the first things that were closed, certainly in Australia, but also in other parts of the world, because there was a lot of concern with, you know, the way that the environment is in the gym, people sweating, and you know, not necessarily the sweat, but the contact that people have with other surfaces and communal sort of showering or share of bathrooms and gym equipment. And it's just a very an environment in which you're likely, those types of contamination and spread of disease is very likely. So cleaning is very important. And I think it's something that's also important is when you're bringing back, as you know, whether it's a sporting team or staff, is that you need to discuss with them their home arrangements and what is the process of them going home and what environment are they going home to. You know, the staff has direct contact with a lot of the athletes, and you know, as we saw in John's presentation, I mean, the impacts of coronavirus are widespread. It's not simply respiratory infection. There's probably other multi-organ effects as well. So you need to understand what the home arrangement is and who are they going home to. Are they going home to people who are, you know, working in high-risk environments? Maybe their family is working in a hospital or in other environments in which their exposure to COVID is quite high. And so you need to understand what their home environment is, both from an education standpoint, but also whether you need to make arrangements and alternative arrangements for homing arrangements. There might be an additional responsibility that you have to take. And we've seen in Australia, in the way they've returned sport in rugby league in Australia, rugby union and AFL, they've developed this concept of the bubble, which they're also looking at in, you know, the NBA potentially, where there's high rates of coronavirus, but having an environment which is sort of what's considered a biosecure environment. Of course, those things are never foolproof, but having an understanding that it's often the staff that are forgotten in those biosecure environment. It's the athletes might have a house to stay and they might be staying in the facility, but it's often the staff that are going home and coming back. So they're the ones that are putting at risk. So you need to have appropriate measures, whether it's, you know, wearing a mask, but also maintaining distancing and hygiene, or whether you actually arrange accommodation facilities. The other thing, and John obviously touched on this as well, is that how do you deal with it if someone is suspected of COVID positive? And this needs to be formulated, you know, in different countries. John was sort of mentioning 10 days as the rule in certain circumstances in terms of quarantining or isolating. You know, in Australia, it's 14 days, and those things are constantly changing. So, but there needs to be policy which is consistent with local health practice as well. So what are the things that you can do within your workplace itself? So you need to have a healthy, safe environment. We sort of discussed upon this, but some of the other things that you need to consider is that how are you arranging the training of athletes as well, or how are you staggering or spreading out people within the gym? You know, in some places, you know, in Australia, for example, at Cricket New South Wales, what some of the things that we've done is that only a certain number of people will train at a time. Initially, that started with 4 people. That's risen now to 10 people. So that's 10 people who are, you know, in the nets at the time. So there might be 3 nets with 10 people, and you know, whereas typically that might have even been double that number, and people are coming at different times. Of course, that might have implications on the quality of the training that they might have, but this is the new normal and that we're working towards. So it's having these contingencies, and hopefully over time, if we develop a vaccine or there's better treatment, and those things might change. But in this particular time, we need to develop a benefit versus risk, and whether, you know, the benefit of training, but also the risk of training with too many people at the same time. So that environment needs to be considering of all those things. So one thing is assessing current risk. And I think this is something that what having this whole situation of COVID-19 is actually asked us to really pause and actually think of what is the actual risk that we've been putting people in already. You know, why don't we have some of these hygiene practices already? I mean, these seem quite normal now. You know, it's obviously coronavirus is quite an infective virus, but there are, you know, we see commonly, you know, respiratory infections as soon as winter hits, and maybe with these hygiene measures, we might be seeing less of those types of illnesses as well. So, you know, this is a good reflection on maybe some of these things that we're taking forward, even when, or if, you know, coronavirus, the effect reduces over time, that maybe some of these practices are something that we'll end up taking forward because they are beneficial to all. You know, social distancing, we sort of touched on a fair bit already, but, you know, this, again, just because it's a workplace doesn't mean that those social distancing rules shouldn't apply. And wherever possible, you should minimize that type of risk. There needs to be a sickness plan. I mean, it's likely that, you know, if this goes on for months and months and we're returning to sport, and these organizations are returning, then we're going to have periods where players or athletes or staff are going to have times where they're getting a test and they're waiting for a test result, and they might, you know, you might not have the number of people who are both, you know, treating athletes or training athletes or athletes themselves. So there needs to be an appropriate sickness plan, and this needs to be open. You know, this needs to be that the athlete doesn't feel as if, you know, they're letting someone down. There needs to be a culture that develops, which makes the athlete feel that they're not considered, you know, they're not training hard enough, or that mentality is no longer applicable in this environment now. So in terms of entry and exit, this is, you know, important. You might see in certain shops, they might have a different entry, different exit. You know, how are people coming in? What is happening at the entrance? You know, and this is, again, a screening process is important. You know, in athletes, ideally have some sort of app system or some sort of system where they can report symptoms even prior to entering the facility. But once they enter the facility, there needs to be an additional screening process. And as soon as this entry process becomes complacent, this will start translating into, you know, complacency within the workplace as well. And the exit process is as important as well, because, as I said before, you know, you need to know what is the, you know, process in which these people are going home. You need to make sure that those standards that they apply within the workplace are maintained outside the workplace as well. So these are some sort of, you know, posters that we've seen in Australia, some of the government posters. You know, this is just outside the environment. So when you're exiting, you still need to maintain those standards. You know, handshaking is you know, there's various new techniques now of greeting people. Maybe we won't see much of handshake in the future, who knows, but you know, minimize that. And if you do happen to contact someone, then make sure you wash your hands. So it's one thing that is, you know, more and more, and we're seeing this obviously as professional sports are returning, is travel. And you know, for a sporting facility, for a sporting team, of course, we want to encourage, we want athletes to be able to compete at the highest levels of care, and this requires at the highest standards, and this requires travel. And you know, so travel, really, when it comes to travel, you need to do a benefit and risk analysis. You know, what is the benefit and what is the risk? And some of the things that we see travel for, obviously, is competition, but we also see travel for training. And you really need to ask the question, I mean, why are we traveling, and what is the aim? You know, is the aim, is there something that we can do? Is it travel necessary? Is it something that we can do in an alternative location? Do we really need to go to so-and-so location, or is this training that we can do locally or in a more, you know, with less travel, less contact, less people involved, less risk of transmission of illness? Can we do this training in an alternative location, or is there a better location? You know, so whenever you decide, particularly overseas, but also, you know, in India, for example, there's a lot of different states have different rates of infection or different lockdown. You know, where is the lowest risk location that we can do our training in? And you know, in Australia, for example, we've seen a lot of the sport is moving to Queensland, where, you know, the rates of community transmission of COVID has been far less than, say, in Victoria. So a lot of the professional teams have now moved to those locations as well. So how do we assess the risk? I mean, one thing, of course, how many people are traveling? And again, this comes down to, and something that we've seen in Australia, where commonly there would be doctors who travel with the team, and there's been situations now where they've utilized local doctors. And, you know, this has some positive and negative effect. Obviously, if a doctor is traveling, they have familiarity with the team. But also, is there a risk of the doctor who's possibly working in some high risk environments? Is it worth them traveling, or can we use local services for this temporary period as well? And how long the travel. So the more people, the more length of the travel, the greater the risk. What is the risk of the destination? What is the accommodation? So particularly overseas, every country has different rules of quarantine. Some countries may be more lax with their quarantine, and this is a concern. So when a country is more lax, maybe an athlete is more likely to step outside or be exposed to people who may be infected. And what are they testing? Are they testing people who are working in these high risk environments? In some countries they might not be doing a lot of testing. So even though they're doing quarantine, you might be still being exposed in the quarantine process itself to a lot of COVID infection. So, those are the rules of quarantine, the restrictions, the government rules, exemptions. Exemptions is an important thing. I mean, I think recently we've seen, is obviously India is due to come to Australia to play cricket. Are there going to be exemptions for them? We've seen exemptions in England, for example, where even though the Pakistan side who's there at the moment, they're going through a quarantine process, but they're being allowed some level of exemption to try and maintain some level of fitness. So, this is an important thing, in terms of when the athlete does return, if they're going through 2 weeks of sitting in a hotel, and then they have an additional risk. So it's important for government bodies to work with government bodies so that an exemption can be arranged, which is both safe and the athletes does require this level of extra care, which is always controversial in the public sphere. But someone whose entire livelihood is dependent on professional sport and is coming to compete at the highest level, it needs to be ensured that those are considered as well when we're making travel arrangements. And I think that something more and more, particularly with overseas travel, is that probably we're going to see more and more doctors having to travel, particularly overseas, obviously, or utilize local services as well. But particularly for international travel, India, the cricket team, for example, regularly doesn't have a doctor that travels with the side, but maybe this is something that needs to occur so that someone is there who's from a professional angle can monitor and assess the level of risk of their team. So coming to the medical services, and I guess someone like myself, the role that I have, but also, as I said, increasingly doctors, and we saw India also developing more and more sports medicine side of things, and this becomes a responsibility in these types of pandemics, whether it's this one or even others in the future. And the most important with everything is preparation, and the preparation, you need to have appropriate personal protective equipment, whether it's simple masks, but also knowing when to use like an N95 or P2 mask, what type of situations you're dealing with, someone who's high risk, having those, being prepared to have those. The doctor is always, in the traveling side, is always looked at as someone who's going to have the hand sanitizer. Even though other people should have that level of responsibility, should be an athlete, should be carrying hand sanitizer, for example, but a doctor, they'll always come to you for those types of things, and you'll get asked to provide those things as well. Basic first aid obviously is a given. A notebook, I think this is a situation, this is really there because documentation is going to be important. And particularly when you're traveling overseas, particularly there's going to be situations where you're dealing with the unknown, and it's important to have that level of documentation. Your response, so responding to different things. So in addition to your normal medical coverage that you'll provide, you'll probably be as part of the medical team, that you will have to be part of the process of developing protocols for training, and for the athlete or for the workplace as well, that you need to be involved in that process because they're looking to you to meet those standards. Everything is they're going to assume that if something is going by in a facility which has doctors, that the doctors approved it. So it's important that you are involved in that process as well, and also in that notification process. And particularly in a traveling situation, when someone is traveling, someone develops certain illnesses, that there are some plans to have isolation. And for example, in India, when Australian teams travel to India regularly, there'll be an extra hotel room booked, which often in India might be diarrhea type illnesses, but you have that isolation room there, so that if someone is sick, that they can be isolated appropriately until appropriate measures are taken. and of course, minimizing contact even within a traveling group as well. The recovering process. So again, cleaning, documenting, reviewing, I mean, these all speak for itself, but also, I think really that review process is the most important, is that you're following up on patients who are sick, understanding that sometimes, just having a negative swab result doesn't mean that they can play with symptoms. So constant review, follow up. If you need to repeat a test, then you have to repeat a test as well. And again, being involved in that cleaning process as well, in terms of equipment is important. So finally, this is something that sort of John sort of mentioned as well, but well-being. And I think, again, this is a responsibility for everyone. It's not simply just the medical team, but something for everyone to really look at, whether it's people in your workplace or even at home. And it's the look, listen, link. Look is, understand that a lot of people may be struggling, whether it's financially, whether it's mentally, and it's important to look and be aware of and understand, particularly people that you're familiar with, recognize situations in which their behavior may not be the same, and they may be struggling in certain capacities. From an athlete perspective, mental health is obviously very important. It's important to everyone, but certainly something that going through a period where you're in lockdown, where maybe you train regularly, maybe you're used to regular physical activity, and then all of a sudden maybe the level of physical activity that you can do is not up to that standard, and this can have a drastic effect on someone's mental health, and it can also have an effect on immune system as well, as we heard previously as well. So recognize that those things can happen. Another thing that to recognize in athletes is these are people who are very regimented often in the way that they undertake routine, and something that additionally can develop are eating disorders or eating behaviors. These can alter in these types of periods where they may have had a strict regime and all of a sudden they've had to shed away from that, and this can also have a detrimental effect as well. So providing that level of education, providing that support, which is multidisciplinary, is important. So be prepared to listen. Listen to people. Listen to the concerns that they may have. Listen deeper. Don't if they've mentioned something or some level of struggle, this is an opportunity for you to listen, and then to take that into the link. And the link is whether you are the one that provides them the level of support, or whether you link them towards community supports or psychological support or social support in whatever capacity as well. This is something that we all have an additional responsibility in the workplace, but obviously particularly the medical staff as well. And that's it. Thank you.
Thank you, Bikram. That was a nice talk, which covered most of the aspects. We have a lot of questions actually from the YouTube chat box. I'll just post you some of the questions, and post that probably we would wind up the session with a word of thanks from Associate Professor Mahendran of Malaysian Association of Sports Medicine. I would request you to stay back, sir. And let me project the questions to you, Bikram.
Yeah.
Probably I can compress these questions into one. Okay. So there are some sports medicine doctors who are attending the webinar today, and they're asking, what's it special in Australia to do a sports medicine practice? And then in team sports, is it necessary to do the COVID screening? And the third question, probably we can have alternatives to ice baths and pool as cool down sessions. Do you do anything special? Bikram.
Yeah. Yes, I'll answer in order. So sports medicine in Australia, how is it so unique? So, in Australia, there's not that many countries in which sports medicine is its own specialization. So Australia is one of them. UK, Ireland, New Zealand. So Australia and New Zealand has a combined program. Other parts of the world, often it's an additional sort of 1 or 2 year, like a master's kind of program, which I think similar in India, but also in America, it's like a family medicine and then an additional 1 or 2 years master's. So in Australia, it's an actual fellowship program, which is minimum 4 years training. So, you know, it's you go through like any physician training program. So one thing in Australia, the way the training sort of works, I guess, is that usually you'd work in a clinical practice. Sometimes you might do additional work with orthopedic surgeons, but one of the strong emphasis is working with sporting teams. So most people through their training will go through and work with sporting organizations, so large sporting organizations, whether professional or semi-professional as well. So immediately you're sort of part of your training is working in a team environment. You'll go overseas, you'll travel, you work with obviously sports science medicine teams as well. So it's quite organized. There's an education and fellowship exam process as well at the end. So in terms of India, I think India, looking obviously at IASM, and I had, as I said, the pleasure of coming to CSS last year and meeting with Dr. Kat, and I think there's a lot of progress being made in terms of professionalizing the training in India. And I think a few Indian origin doctors have come now to Australia and done observerships as well in Australia to see sports medicine practice. So I think there will be more and more partnership with India, and I think the Australian model is I think probably leading in sports medicine. So it's something to keep your eye on. And I think as an Indian, if you're interested in sports medicine, then I definitely encourage Australia and New Zealand would be the two places where I'd definitely recommend, because of the professional training that there is, at least to come and observe, as opposed to other parts where I think South Africa as well, actually. So, but other parts of the world where the training might not be as structured. So, I'd encourage them to sort of be in touch with sports medical doctors in Australia. So so coming to COVID screening in team sports, in Australia, the team sports that we've seen, AFL and rugby league especially, were the ones that restarted sport, and recently the A-League, which is a professional soccer body. And the way that it was done here was that most teams had a base city for they either stayed in Sydney, initially Melbourne, but now Sydney and Brisbane mainly. But prior to entering into this sort of biosecure environment, they'd have a COVID test. And then after having the COVID test, they'd be isolating. And then once the results of isolation, then they'll go through a sort of chartered transport system into this sort of secure environment. One of the things that have happened in those times, so the professional sports have sort of returned since the start of this month. So there've been one or two. So for example, if a team is based in Sydney and some of those players might still be returning home, and so they have children, and if those children or their contacts have had some level of contact, even if it's might be considered second or third degree type contact, they've had to have a repeat test as well. So it hasn't been so much a structured periodic testing. I think maybe over time we'll know if that's a requirement or not, but at the moment the testing is initial before coming into the quarantine process, and then if there's any having a slightly more broad view of indications to test, and ensuring that the environment that actually go to is biosecure as well. So these the players that have been forced to sign sort of contracts which they can't go out to cafes, they can't go out to restaurants, so they are restricted in what they can do, which as I said before has great pressure on their mental health and well-being. But having that such a strict regimented environment has probably meant, so far at least, we haven't had to have periodic testing. So I'm not sure if there's any clinical evidence for that at the moment, but maybe something that will evolve over time. In terms of cool down sessions, so there are some alternatives. I mean, in Australia, actually not so much in Australia, but in the NFL, for example, they use a lot of personalized sort of ice recovery devices, which can be quite expensive, but there's various brands which are marketing cryotherapy type, portable sort of cryotherapy type devices, which are for the athlete as well. So you'll see them, you might see on TV, sometimes they've got these sort of large, cylindrical things around their legs and arms, and even their chest as well, but not as common in the chest, but they're devices which are effectively doing what icing does, but obviously far more expensive. you know, in Australia, the other thing that are used in professional rugby sides where haven't invested in those types of devices, they've just used personal, like an individual only ice bath. So of course, you know, that is not as practical to, carry around, but a lot of the recovery has now become remote. So instead of, which is not ideal necessarily, but the recovery process might be in the person's home instead, as opposed to necessarily straight after the game. So they'll go straight to their accommodation and then do their personal recovery in those situations. So part of it is logistics. Yes, there are devices which are used, but they can be quite expensive. They're $400 or $500 for those personalized ice cryotherapy devices.
Thank you, Dr. Bikram, for being with us and enlightening us
Thanks.
about what's happening in Australia regarding COVID and sports medicine. Looking forward to have great collaborations with you in future webinars. I'm looking forward to see you again, probably meet you again in Australia. Thank you.
No, thank you. We'll see you in Australia, maybe.
And may I request Professor Mahendran Appakutti from the UITM to offer his word of thanks to this wonderful group of faculty and the audience in the YouTube also.
Thank you, Dr. Tiaga. And I think everyone will agree that we had a very good knowledge and also exciting talk about the athletes and also about the COVID-19, which is still affecting many countries, and how is this thing will be happen to athletes. What will be the prevention? What will be the taking management on that? I think covered by very nicely by Prof. John. I really thank. He had mentioned nice word, exercise as an immune booster. That is a very good thing. And I, on behalf of your ITM and also from the Malaysian Association of Sport Medicine, would like to thank the Indian Association of Sport Medicine, and also Center for Sports Science and Sri Ramachandra Institute for Higher Education and Research for the excellent present, what they call the overview of this webinar. My heartmost thanks to Prof. Arumugam and Dr. Tiaga. You have done a very good job. Your team is excellent. I must thank all the people inside there, Vikram and Dr. Harish and Janani, whoever behind the team, they have done a good job. I think Dr. Bikram has put a nice word of safety. That is the most important now. And all of us, when we go back after this webinar, please take care of yourself. That is more important now. I think in Malaysia, we already come to the recovery phase, but numbers are still increasing, but it's fluctuating. But I think that safety is a very important issue. So with that, we will go the next one tomorrow on sports surgery. I think please come. Prof. Chan is there. Dr. Chan will be there tomorrow. He will be talking, and then we got a very good presenters from all countries. Yes, so from South Africa, Oman, Malaysia, UAE, and India. Prof. Arumugam is going to talk. I'm waiting for all these talks and everything. Though I'm not a surgeon, I'm not in the medical field, but I'm a nutritionist. I think it's a very interesting topic going to be discussed tomorrow as well. With that, I thank you very much on behalf of the organizing committee to all the viewers and the listeners there. Please take care. Thank you very much. Dr. Tiaga, back to you.
Thank you, Professor Mahendran, and thanks one and all, and especially thanks to Professor Dr. Halim and Dr. Chan for joining and making this occasion very special. See you all tomorrow.